PHR209 basic biopharmaceuticals. So drugs affect the body, and also the body will affect the drugs. So biopharmaceuticals, pharmacokinetics, pharmacodynamics. All right, so we'll go through the effects of drugs on the body, talk about the graph, blood concentration time profile graph. That way you can kind of estimate when we need to redose a patient. And then we'll talk about what our body does to a drug. So this is pharmacokinetics. So our body will absorb the drug, distribute the drug, metabolize it, and then excrete it. And then last thing we'll touch upon today will be drugs half-life. That's how you know how long a drug stays in a patient's system. All right, how a drug works. Well, we can manipulate drugs by changing the drug concentration or where we administer the drug in order to alter its effect. So if we want a fast response, then we use a high concentration, right? If we want a slower, steady response, then we might use a lower concentration. Site of action is the place where the drug causes an effect to occur. So if the drug never gets to the site of action, does it work? No, it has to get to there. It can go into the body, but it never interacts with the site of action. It's not going to work. Receptor. So this is the exact part of the body that the drug will interact with. And this is going to be at the molecular level. So molecule specific. So smaller than cells, this is how specific a drug is able to recognize the receptor. Think of the receptor as the lock and the key as the drug. Or this could be a hormone or any other chemical messenger. They work the same way. So there are some keys that will only open one lock, right? So there's some drugs that are very specific. They will only target one receptor. But there are some locks that can, or some keys that can open up many locks, like a master key, right? So there are some drugs that can interact with multiple receptors. Receptor site. So there's two basic sites where the drug receptors will be. So if you recall from anatomy, the cell wall is made up of, what's the cell wall made up of? Lipids, right? So it's a fat structure. And our body's mostly water. So outside the cell there is water. And inside the cell there is water. But what determines inside and outside is this fat layer. And we know that oil and water doesn't mix, so any water from the outside will stay on the outside, and any contents that's water on the inside will stay on the inside. So that's what allows your body or your cells to create a border, the cell membrane, made out of lipids. So on the outside are water-soluble drugs, because if I'm water-soluble, I cannot pass through the cell membrane, because the cell membrane is made out of fat. Conversely, if I am a fat-based molecule, right, like dissolves like, I can wiggle my way through into the cell easily. So my receptors are going to be on the inside of the cell. So that's the main difference. Outside, water-soluble, aka protein-based drugs, protein-based hormones. On the inside, fat-based or cholesterol-based. All your steroid hormones, they are fat-based. And what they do is, what's in the center of your cell? The nucleus. There's DNA inside the nucleus, and it has its own fat membrane as well, the nuclear envelope. And since I am fat soluble, I can now enter into the cell and directly turn on or turn off DNA. Right? So these fat soluble compounds, chemicals can direct your DNA very quickly, or affect your DNA very quickly. Type of drug actions. Physical. You guys ever heard of butt paste? Any mothers here? No? So it's a diaper rash ointment to prevent diaper rash.
I guess that.
Butt paste ointment. So it's a protective layer because when they urinate, it's a lot of acidic water and it's going to irritate the skin. But if you have a layer of ointment, which is oil, it prevents the water from affecting the skin. So it blocks it. React chemically. So if you have an upset stomach, you have too much acid. So what do you take? Tums, Malox. So what is Tums and Malox?
Calcium or potassium.
Yeah, they're a base. So we take an acid and a base together and they neutralize each other. So they chemically react. So that's how some drugs work. Interact with pathogens. So we mentioned a little bit for a discussion how one type of antibiotic works. So penicillins work by poking holes in the cell wall of bacteria. So that's how it interacts with pathogens. What is osmolarity? Have you guys ever heard of that word?
Osmosis.
Yeah, so very good. So
The
blood,
changing?
well, it measures kind of water pressure based on how much stuff is in it. So for blood, human blood, there is 300 milliosmoles of pressure. Right? So that means blood is not zero, right? There's stuff in it. So when you mix stuff in your blood, it has to have about the same amount of stuff. If it has too little or too much, it can damage the blood cells.
Like a maximum capacity.
Yeah, like concentration, based on concentration. So osmolarity controls which way water goes, right? So if you have a lot of salt, you eat a lot of salt, what happens to you? What do you feel? You feel thirsty, right? So anytime there's salt, it always pulls in water. So when you drink seawater, what happens? It sucks in your body's water. It dehydrates you even more. So osmolarity is which way does the water flow? And we can use that for dialysis, right? Kidney dialysis. Anti-neoplastics. What's anti? For or against?
Against.
Against. What's neo? New or old?
New.
New, right? And plastic is formation. So this is against new formation. So what type of cells grow very fast? Yeah, tumors and cancer cells. So these drugs are against cancer cells. And how do they work? They're like poison. So the cancer cell takes in poison and then they can't really divide anymore. And that's how we kill cancer, is we give people poison, but it also affects healthy cells. So that's why they look so sickly when they're on treatment, because it kills and destroys their healthy cells as well. We nurse them back to health. Next month, we repeat. We give them more poison. Hopefully the cancer shrinks. They recover. The cancer recover. We give them more poison. Cancer shrinks. And it's a cycle until the cancer disappears. Complexation. So that's like a weird term for just say binding, right? So for example, I got a key, got a bunch of teeth cut out, and you wrap tape around it. Right? I wrapped it with a bunch of tape. Will it fit in the keyhole anymore? Will it fit in the lock anymore? No, right? So it's not going to interact. So that's what complexing does. When you bind with your drug or bind with the compound, pretty much allows it to pass through without affecting receptors. So antidotes. A lot of antidotes will bind with poisons or drugs, so your body can get rid of them. Modify biochemical or metabolic processes. So think of things that slow or increase your metabolism. All right. Agonists versus antagonists. So agonist is for or against?
Agonist is for.
For, right? And then antagonist is against, right? But these are receptors. So you have to think of it in terms of activation of receptors. So an agonist activates the receptors, right? An antagonist blocks the receptors. But let me give you an example of two agonists, right? So most cars have two pedals. On the left side, there's the pedal, and on the right side, right? Which is the pedal on the left side? That's your brake pedal, right? And the one on the right is the, and you guys don't drive a stick, right? Americans don't drive a stick anymore. We're just lazy. We want to control the iPod, not the steering wheel. So, if you activate the brake, what happens? You
slow down.
You slow down. So
I feel like this is a trick question.
It's not a trick question, no. But you have to think of it this way.
Slow down, right?
Right. So I activated the brake, I slow down. If I activate the gas, what happened?
You go.
I speed up, right? But did I activate something? Yeah, I activated something. So it doesn't matter what the antagonist does. The normal process of the brake is to slow down. The normal process when you activate the gas is to speed up, all right? An antagonist, I'll give you an example in your car, right? It gets a little hot on a long road trip, so I get this nice round water bottle, and I'm fumbling around with the cap, and then I dropped it, and it rolled behind the brake pedal. So it's now right here behind the brake pedal. And I try to press the brake. What happens? Doesn't activate it. It blocks the action, right? So it's so big that it blocks the gas as well. Now I try to speed up. What happens? It blocks the action. Right? So now you guys kind of get it? If it activates a receptor, then it's an agonist, regardless if it speeds you up or slows you down. It activated the receptor. Whereas an antagonist, it just blocks. It blocks the receptor. It can get in the way. It can like bind with the drug and complex with it, but it doesn't activate the receptor. So most of the time, an antagonist will block the receptor and activity decreases. So if your brake activity decreases, what happens? You keep on going fast, right? If your gas pedal decreases, then you slow down, right? You're not putting more throttle in, you slow down.
So an agonist can activate, I guess, the blocking action?
An agonist?
Yeah.
An agonist only does...
Would that be considered activating the blocking action?
Yeah, that would be pressing the brake.
Okay, so it would...
Yeah.
It also works for the brake as well as for the gas.
Yeah, but you activated something, right?
Activated. Gotcha.
So I activated the brake, slows me down. I activate the gas, speeds me up. Same thing in your brain. The brain sends a signal to the heart, hey, slow down or speed up. But it activated something, right? All right, so think of it that way. We'll return to that topic later on as well. Decrease and increase sensitivity. So this has to do with the number of receptors. Decrease sensitivity. So this occurs maybe in diabetes. Right? So if you eat a lot of food, your blood sugar goes up, your body produces tons and tons of insulin. So from the pancreas, you dump tons of insulin, it goes in your blood, and all the cells in your body takes it up. But you're a glut. So 2 hours later, you eat another gigantic meal, and your pancreas releases tons and tons of insulin again. And your cell goes, oh, more insulin. So it uses the sugar. But you're in Vegas buffet, 2 hours later, guess what you do? You eat some more. So now there's all this insulin, and the cell goes, you know what, there's insulin here all the time. Whatever. Don't worry about it. So you might lose the number of receptors And when there is insulin, your body doesn't respond as much, right? So you become desensitized. You used to do a little, but now you have to do a lot more to get the same effect. Right? The opposite of that is when you try to quit. So let's say smoking. Right? Anybody smoke? The first few days, they say, the first 3 days to 1 week, they say, is the hardest to stop quitting smoking because your brain cell goes, where's all the nicotine? Let's grow more receptors. So your brain will actually change its chemistry, make more receptors, because it's thinking, I'm missing the nicotine, right? So it's trying to get and capture all the nicotine it can. So that's why it's so hard, and you get a little, angry? A little bitchy, because your brain is going, give me nicotine, and it even grows extended, extra receptors trying to capture any nicotine. So for many drugs, we gotta slowly taper you up. And can you quit your drugs right away? No, we gotta slowly taper you down as well. So for example, this is steroids. I'm not talking about like anabolic steroids, but they work the same way. Here I'm talking about steroids for inflammation. So if you have an injury and there's a lot of swelling, they can't just give you a high dose of steroids right away. Sometimes they'll have to step you up. And they can't take you off steroids because your body needs to readjust. So they'll slowly taper you off so you won't go through any of the withdrawal symptoms. What is the site of action?
Place where a drug causes an effect to occur.
The site of action. So if the drug does not go to the site of action, then it's just going to pass right through your body. Right? What is an agonist? A, B, C, or D? So they activate receptors. So here I'm pressing on the gas pedal, right? I activate the gas pedal. And here I'm activating the brake pedal. So as long as you activate, you're an agonist. If you block, then you're an antagonist. If you deactivate, then you are an antagonist. Dose response curve. So you take one dose, it causes this much effect. You take this much drug, then it's going to cause that much effect. If you take more drug, more effect. But here it kind of tapers off. Doesn't matter. All the way out here, you can take as much as you want. There's not going to be much difference in the effects. So that's the diminishing return. However, you can't use this to compare one person to the next because people respond differently, right? So what might make people respond differently to the same amount of drug? I take this much, it might affect me that much. You take this much, it might affect you even more.
Age.
So age, what else? Ethnicity, so genetics. Sex, right? So who carries more water?
Females.
I don't know. Who carries more muscle? Who carries more fat? Right? So that all affects how much a drug affects you. So it's kind of counterintuitive. So if you have fat, is there water in fat? Yeah, see. What floats, water or fat? Fat floats, right? So if there's fat, is there any water?
Water doesn't float?
No, fat floats on water. What floats, water or fat when they're mixed? The fat, right? The fat rises up. So that'll depend. If you have more body fat, then more fat-soluble drugs will distribute in your body. However, you have less blood volume because you have less muscle, right? So it's a little bit different. So it's all the human variability. Have you ever gotten a notice from the DMV and they give you the blood alcohol chart? It tells you if you're a male, you weigh this much, you can take this many drinks before you get a DUI. If you're a female, you never seen that chart?
I have it on my fridge just in
Yeah.
case.
So our legal limit is 0.8% blood alcohol concentration. So that is checking bodily fluids. So blood is just one bodily fluid, and it's the most common. We can take out your spinal fluid if we wanted to and check it, or any other fluid, but blood is relatively easy to assess. So here is the time profile. So time 0 is when you initially took the dose, and then blood concentration goes up, and then as your body changes it and get rid of it, your blood concentration goes down over time. So this is what they will study during clinical trials to see how your body affects the drugs. All right, so different parts of the profile. So minimum effective concentration. So this is the minimum level where a response will occur. So as soon as you take the drug at time 0, is the drug working here? No, right? So what concentration does the blood need to reach in order for a response to happen? 2, right? So you take it right now, not working, not working, not working, not working. It's building up in your system, and then once it reaches that level, then it's actually working. Enough of the receptors are being occupied that it's causing an effect. So very good. So at about blood concentration of 2 is MEC. So here it is identified. Just follow it over to the value. Onset of action. So I took the drug here at time 0. It's not working. How long did it take from when I first took the drug to when it starts to work? How long did that take? Onset of action. It took from here to here. So yeah, 2 hours, whatever it is. 2 hours for the drug to start working.
Wouldn't that vary, I guess?
Yeah, this is just an example of one drug. So if you gave it somebody a different route, it'll change. If a different dosage form will change. So this is just a generic example. So we're just identifying the different parts. So for therapeutic window, that is the value between MEC, where it starts to have an effect, and MTC, where there is negative effects. So what is the range here? How much range concentration do we have to play with?
2.
Yeah, so about 2 concentration units. So we're going to have to try to keep that patient within that therapeutic window at all times. So let me ask you a question. With this drug concentration profile, when would you give the next dose in order to keep them above MEC but below MTC? So I took it at time 0. When would you give them the second dose?
Every 10 hours?
So at 10? So if I give them at 10, do they have enough drug to work?
Maybe 2 hours before, just
So
to keep it consistent.
yeah, so here's the next one, if you take it. So yeah, I'd probably give it to them at around 8 hours. So during clinical trials, this is what they monitor, and they kind of see, hey, what concentration do we want to use, and how often should we give them their drug? That way we stay within the therapeutic window. Duration of action. How long is this drug working for? In other words, how long is my blood concentration above minimum effective concentration? So if I take a dose, how long does it work for? So it's not working, not working, not working, not working, not working, not working, 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 working. Oh, no longer working. So how long is it working for? from here to here, the drug is working. So how many? Yeah, so it'll work for 8 hours. So the duration of action of one dose would be about 8 hours. All right, so that's just the terms for the different parts of the curve. You'll just probably have questions like matching what those terms are, or identify the graph. Changes in blood concentration profile reflects changes at the site of action. So blood. Does your blood go everywhere in your body? Pretty much, right? Mostly. There's a couple spots in your body where there's no blood supply. Yeah, where?
Your balls?
In your eyes. Your testes have blood. You gotta feed your sperm. Your eyes, your eyeball, right? Inside, it's all jelly. And your on the outside, but on the inside there's no. And then your joint capsules, right? So that means if drug needs to go into your eye, what do we have to do? Poke it in there. If it needs to go to the joint, we might have to inject it into the joint. So that means if your blood concentration goes down, most likely the concentration at where the drug is working also goes down as well. Peak is the highest, and then the lowest is the trough. Usually we take the trough right before the next dose. Right? Some drugs are toxic. We always take blood values before. Other drugs, not too bad. We'll just give it on a regular regimen. So for drugs that you have to adjust because of toxicity, just wait until you make it. The doctor might make changes before the next dose. Name me a drug that cannot be predicted based on the blood concentration. Name me one drug where you can have tons of it in your blood, but it's not affecting you.
Alcohol?
No, alcohol doesn't matter. It globally affects you. Alcohol affects your entire body, every receptor. I'll give you an example.
Insulin?
THC in your blood. It doesn't matter how much it is, it affects everyone differently. Because it doesn't matter how much is in your blood, it needs to be at the site of action to affect you. So if it's not at the site of action, so in the parts of your brain which they can't detect, then they don't know how much it affects you. So they're trying to get 5 micrograms as the limit, but the science isn't there yet. So that's why there is no DUI limit for THC. Wherever alcohol, what's the limit?
0.8?
0.8%. This guy knows. So 0.08, 0.8% blood alcohol concentration. That is definite DUI in California. But if you're pulled over, this stuff, any amount is a DUI. So just be careful. They haven't established a limit yet. All right, definitions. What is MEC? A, B, C, D, or E?
What time to make this reach in the first place?
MEC. Minimum effective concentration. B, right? The blood concentration needed to produce a response. So you need this much drug. Onset of action. When you first take the drug, it may not work right away. How long does it take to kick in? The time MEC is reached and the response has occurred, yeah. So take it at time 0, nothing works. Wait a little bit. Once it starts kicking in, that is the onset of action. Minimum toxic concentration. Minimum toxic. Overdose. Which one is like an overdose? Yeah. Increase the risk of undesired effects. So if you give somebody too much morphine, you're going to shut down their breathing, paralyze them. Therapeutic window. So that one is the range, right? So you want to stay above MEC, but below toxic concentration. And then lastly, duration of action. The length of time drug concentration is above MEC. All right, ADME. So there's two terms that are commonly used interchangeably, but that's incorrect. Pharmacodynamics and pharmacokinetics. Pharmacodynamics is what the drug does to you, does to your body. So D, dynamic, is for drug. What we're going to talk about is pharmacokinetics, what our body does to the drug. So what our body does to the drug is it will absorb the drug, it'll distribute the drug, it'll metabolize it, and then excrete it. So ADME, that's what our body does to the drug, pharmacokinetics. So on the blood concentration time profile, they kind of outlined where ADME occurs. So as soon as you take the drug, you'll start to absorb it. So absorption means getting it into the blood. So once it gets to the blood, we will then start to distribute it, take it throughout the body, and then we will metabolize it. Metabolism is just a fancy way of saying we change the chemical, in this case the drug, and excretion is to get it out of the body. Okay? So M&E kind of occurs together. So as soon as you start changing the drug compound, your body is then able to get rid of it. Very important, there's going to be two D terms and two E terms. They're very similar. All right, so we have distribution and the term disposition. So drug disposition is all four steps. So ADME all together is known as drug disposition. So DIS and distribution, very similar terms, but entirely different things. Distribution is just one part of drug disposition, which is everything all together. And notice that they combined M&E, metabolism, and excretion. Together, M&E is known as drug elimination. So you have elimination and you have excretion. So just be very careful. They use very similar sounding terms. Drug disposition, ADME, drug distribution, getting it to the site of action. Metabolism and excretion, collectively known as drug elimination. All right, absorption. So from the dosage form into the blood. So we can manipulate how fast this occurs. So what is faster, by mouth or IV?
IV.
Getting into the blood, IV is almost automatic, right? If you take something by mouth, how long does it take to get to the blood?
Hours.
Up to an hour, right? So it takes a while. So it's not minutes, it's not 2 minutes, it's not 5 minutes. It might be 15, 20, half hour, up to an hour. Right? So the fastest substance that you can probably get in is IV. Distribution. Now that it is in the blood, your body needs to get it to the site of action. So what determines how fast it gets to the site of action?
Heart rate.
Yeah, your heart rate. How fast your heart is beating. Right? Sometimes your body size will determine how long it takes. Your metabolism, right? Where does your metabolism occur? Which organ in the body does most of the chemical processing? Just name a liver. Just name an organ. I just said it, right? I was thinking it. Yeah, the liver. So tucked right here, under your rib cage on the right side is this big old sack of cells, very homogeneous, and all it does is just changes chemicals. Now, if there is a chemical that the liver can't change and get rid of, it holds on to it. So throughout your lifetime, your liver is actually holding on to toxins. So if you get hit in the liver, what happens?
You die?
You don't die, but you're going to get sick. And it hurts a lot because the liver is going to spew all those toxins that it's been collecting because it can't get rid of it. So you're going to be prison riot. Yeah, it goes crazy. All those toxins go a little bit crazy, and you feel sick for a few days afterwards. So liver damage can be very effective. And then lastly, excretion. What is the organ of excretion? Where's most of the excretion occur? Yeah. So very good. So the kidneys are your blood filters, right? So the liver dumps the chemicals that it changes, metabolites. So anything that the drug breaks down into is called a drug metabolite. So that's the byproducts of metabolism, right? Metabolites. So the liver will now break down the drug, sends the metabolites into the blood, right? Back to the blood, and then the kidneys will filter out the metabolites, and then you just urinate most of it out. Now, other parts of your body will excrete drugs. Some drugs go through your skin. Some drugs, you exhale them out. Movement of the drug, right? So diffusion. So to diffuse, to spread out. And diffusion, when it is passive, it requires no energy, right? No energy at all. So we always go from high to low. Anytime you go from high concentration to low, no energy required. So for example, you got a little spray bottle, right? And you sprayed it here in front of the room. And all you have to do is wait, and those molecules will spread themselves throughout the whole room. So they diffuse. Doesn't take any energy. I don't have to wave, I don't have to spread it around. Just the molecules bouncing around will spread themselves. So they will go from high concentration to low. Biologic membranes, we alluded to this cell membrane made out of fat and protein. So it's a phospholipid bilayer. Right? So cell membranes are called phospholipid bilayers. So they are fat-like. So that's what lipodal means. They're fat-like. So what you have is just a bubble of lipids. And on the inside there's water, and on the outside there's water. So that means if you are fat-soluble, hydrophobic, you fear water, then you can wiggle your way through the cell membrane. If you are water-based, or in this case protein-based drugs, then you're hydrophilic. You're going to be repelled by the cell wall. Right? So protein drugs will have receptors on the outside, and then fat-based drugs will sneak their way into the cell. To get water-based drugs, water-soluble drugs in, you might have special channels that allows for water and ions to go in. So if I'm charged like an ion, if I have a plus charge or a negative charge on me, like sodium or chloride, can I easily pass through? Are ions hydrophobic or hydrophilic? Are they like water or are they like fat?
Fat.
They're going to be like water. So, hey, it's a 50-50 guess. Better than Vegas odds. You took a stab at it. So anything that is ionic is polar and it'll act like water. So that means their receptors will be on the outside, and it'll be harder for charged particles to pass through the lipid layer of the cell membrane. active transport. Conversely, from passive transport, it is going to require energy, and you're going to go from low concentration to high concentration. So let's think backwards. So you sprayed that air freshener throughout the entire room. It's everywhere, right? It's low concentration. Now you found out that somebody was allergic. You're going to have to run around the room and put all those molecules back in the bottle. High concentration. Is that going to take energy? Yeah, it's going to take tons and tons of energy, going from low concentration back to high. Half-life. You guys ever heard of radioactivity? How long things will be toxic for or poisonous for, right? So Fukushima, Chernobyl, are those places safe to return to? No, it's that uranium stuff. They say it's like millions, hundreds of thousands of years before it's safe to go back. Maybe millions of years. So drugs, radioactivity, right? They break down, they lose energy at the same rate. So we can predict how long a drug stays in the body. So the half-life is the time it takes for your body to get rid of half of the drug, right? So let's say there is 100% of your initial dose. You took it right now, right? The time it takes for your body to only have 50% of the drug left, that is one half-life, right? What's half of 50? For the drug to reach 25% concentration in your body from the initial dose, it would take one half-life, two half-lives, right? What's half of 25? To get drug concentration down to 12.5%, it would take 3 half-lives. Right? To get it down to 6.25%, another half, it would take 4 half-lives. And if you go to the 5th half-life, they say, hey, the drug is pretty much out of your system. So that's how we determine when a drug is out of your system, after 5 half-lives. Right? So let's see here. Valium has a half-life of 72 hours. How many hours will it take for the blood concentration to reach 12.5% of the initial? So how many half-life does it take to get down to 12.5%? 3 half-lives, right? So going from 100% to 50, how much time was that? 72 hours, right? That's the half-life of Valium. So going from 50% to 25%, how long did that take? Another 72 hours. And to go from 50 to what we want, 12%, it took another 72 hours. So how long would it take to reach 12.5%? So 72 plus 72 plus 72 is a long time. So that's why a lot of people overdose on Valium, because they'll take it, but it takes a very long time to get out of your system. And they overdose without knowing it. So don't mix your Valium with alcohol and all the other drugs that celebrities did. All right, now your time to try. How long would it take to eliminate a drug with a half-life of 12 hours? Let's go back to the previous side and see how long it's required to eliminate a drug. So how many half-lives does it take to eliminate a drug? You got to read. Previous slide. What does it say on the previous slide? How many half-lives? It takes... How many half-lives? That's the half-life time. So let's say you had 100% of the drug. To get down to 50%, that took 12 hours. Now to get down to 25%, that took this drug another 12 hours. To get down to 12.5%, it took 12 hours. So how many half-lives does it take in order for this drug to be eliminated? And how long would that take? So read the previous slide. What does the previous slide say? How many half-lives? How many half-lives? Read it. It takes No, it takes, how many? Read it. Read the slide. How many half-lives does it take? 5 half-lives. So all you have to do is take the half-life and multiply by 5. That's it. So you gotta find that information on the previous slide and just multiply. So this drug has a half-life of 12 hours. 5 half-lives is 5 times 12. So it's just 60 hours. So this is just 1 half-life, 2 half-life, 3 half-life, 4. It's the 5th half-life that they consider it eliminated. So just look at the previous slide. Where would you expect to find the receptor for a hydrophilic drug? If I'm hydrophilic, am I water-based or fat-based?
Water-based.
So if I'm water-based, are my receptors on the outside or on the inside? Can I go through? So it would be outside the cell because water-based molecules, it's harder to penetrate the lipid membrane. So very important concept, and that's how profound estrogen, testosterone is to your body. Because they're fat soluble, they directly turn on and turn off genes. Turn it off, turn on your DNA. All right, so that was part 1. We'll finish up basic pharmaceuticals, biopharmaceuticals on Thursday. Let's go on and do the homework assignment.